Okay, so today we are going to look at the appendicular skeleton. This is a skeleton that's going to make up the limbs, so if you imagine the upper limb and the lower limb, okay, as well as the girdles. Now the term girdle in this sense, these are the structures that are going to actually attach the limbs to the body. So when we talk about the pectoral girdle, when we hear anything pectoral has to do with this region right here, right of the chest. So the pectoral girdle is actually what's going to connect the upper limbs to the body, right? And this is what we would commonly call the shoulders. The pelvic girdle is what's going to connect the lower limb to the body, and it's what we would call usually the hips. Okay, this is a more complicated structure because we're going to see a lot more interaction between the appendicular skeleton and the axial skeleton at the pelvic girdle. Now here we have to be careful because we all know these parts of the body, but we know kind of the common speak terms. So we want to make sure we're using the correct anatomical terms for all these parts of the body. So we will begin with the pectoral girdle. Okay, it's also called the shoulder girdle. What we are going to see here is we have the anterior clavicles in the front. Okay, the clavicles commonly called the collarbone. And in the posterior area, we have the scapula. The scapula is what you would commonly call the shoulder blade. The scapula is actually quite a complex bone. This is where we're going to see the point of attachment for the upper limbs. The bony attachment, bone-to-bone connection between the upper limbs and the axial skeleton is actually quite limited. And the reason for that limited bone-to-bone attachment is so that we have maximal movement. Right? The range of motion that we have in our upper limb is huge if you compare us to any of our four-legged relatives, right? Where they use both their front and rear limbs for walking, right? For strength. Most of us cannot walk on our forelimbs, right? We cannot walk on our arms. What we have, instead of having strength or weight bearing, we have a huge range of motion. The bones are going to provide attachment points for the muscles, and we have quite a good deal of musculature here. Now, we are not covering the gross anatomy of the muscles in A&P 1. I have to, at times, mention a muscle here, mention a muscle there. I won't test you on the names of those muscles, okay? But if you start thinking about them and putting them in place and understanding how the words go together, it'll actually help you in the long run in terms of knowing the names of the muscles. So here is a visual representation of the pectoral girdle. Okay. Here we have our clavicle. We'll take a closer look at the clavicle. The clavicle is going to articulate in the medial or towards the middle of the body aspect. The clavicle is going to articulate with the sternum, right, specifically with the region of the sternum that we call the manubrium. Right, so this is where we have connection between the appendicular and axial skeletons. This joint here, when we cover joints next week, this is called the sternoclavicular joint because it's between the sternum and the clavicle. This very complex bone, this is the scapula. We will look at the different regions of the scapula. The scapula is going to connect to the clavicle here at what's called the acromioclavicular joint. A lot of the joints that we will talk about are named in such a fashion in that they are named by the two bones or the two regions of bones that articulate. Now this bone here, this is going to be the first bone of the brachium or the arm, and this bone will be called the humerus, and we'll see this as well. Here we're seeing the bones as they would be articulated, but with all of the soft tissue removed. So all of the cartilage, all of the ligaments, all of the tendons, all of the muscles removed. The collarbone, right, correctly called the clavicle, these bones have a double curve to them. We have two different ends. We have a lateral end, which would face towards the outside, and we call that the acromial end. That will articulate with the scapula, specifically with a part of the scapula called the acromion, hence the name the acromial end. The sternal region is medial, and that's going to articulate with the sternum, specifically the manubrium of the sternum. This clavicle is actually quite important. It helps to brace the shoulder outward. This actually keeps the arms and shoulders away from the body rather than having them fall into the body. It serves as the only bone-to-bone attachment of the upper limb. Any arm movement that involves the upper arm, the brachium, and the shoulder involves muscles that attach to or go through the clavicle. If anyone has ever broken their clavicle, This is one of the worst breaks to have because you have to wear a large immobilizer for the entirety of your arm because you really can't move your upper arm as this bone is trying to heal. And it can't be casted, right, because it's here. If we were to take a look at the collarbone, this is the collarbone. This is a right clavicle, so the right side of the body. This is the superior view and the inferior view, the anterior and posterior. The acromial end is lateral, so that's towards the outside of the body. The medial end would be where we have the sternal. So we see this curving here. There is also a curving. Not only do we have this kind of S-shaped curving, there's also a curving that goes in the up-down fashion as well. Clavicle will articulate with a region of the scapula called the acromion. The scapula is quite a complex bone. It has a basic triangular shape. There is a flat region that's called the blade of it. This lies on the dorsal surface of the body just on top of the rib cage, so it has a slight curve to it, and that curve nicely matches with the curve of the rib cage. There are some major markings that we will look at. Now this is a right scapula, so if you're looking at the right aspect, and again this is always looking at a patient or looking at an individual, this would be their right aspect. It's the anterior aspect, so if you could imagine a person facing you and you remove the rest of the body, leaving the scapula in place. That's the orientation that you're seeing this. So this region here, this is called the subscapular fossa. It is a slight indent here. That's going to sit on the curve of the rib cage. Subscapular meaning below the scapula. Now there are three angles. This has a roughly triangular shape, so it has three angles. Here we have the inferior angle. Here we have the superior angle. And then not shown over on this diagram, not labeled, but we also have a lateral angle. In addition to angles, we have borders, right? If we think of this like a triangle, triangles have three sides and three edges or three lines. So here's our lateral border, medial border, okay, and this would be the superior border. If we look at this same scapula now from the posterior aspect, the most obvious is this spine. This is the scapular spine. Right? This is a very high ridge of bone that comes up and becomes a projection that goes towards the anterior end, and that is the acromion. The acromion is where the clavicle will articulate. This spine forms two different fossa, right? So we have the supraspinous fossa above it and the infraspinous fossa below it. This is where two major muscles will sit. Right? So the scapula is actually kind of held in place by those muscles. Okay. Again, you can see that lateral angle, so that just keeps you where the directionality is. Over here, we also have something called the coracoid process. Please do not confuse that with the coronoid process that we saw in the mandible. Right? Coracoid. Now, this is a very important view. Here we see the articular surface of the scapula, so where the humerus would actually articulate in. This is in a more straight up and down fashion than it would actually be in the body. In the body, this would be tilted forward, right, so it could sit on the curve of the rib cage more. So now we can see the subscapular fossa. Okay. The infraspinous fossa would be over here. This region here is called the glenoid cavity, also called the glenoid fossa. This glenoid cavity or glenoid fossa is where the rounded head of the humerus will articulate. Okay, and that's where we have the movement of the brachium relative to the shoulder. The upper projection is the acromion. This is where the clavicle will articulate in the acromioclavicular joint. And then we have the coracoid process. So this forms a little notch of bone where the head of the humerus is going to sit. It's not a very tight connection, right? It's not a lot of tight bone around bone, and that's what gives us a larger range of motion in the shoulder. And when we compare this later to the hip, which also has a ball and socket joint, and we'll see this in chapter 8, there's much less movement in the hip because there's a much tighter connection between the bones. So we'll then look at the upper limb. The upper limb really contains three main parts. The upper limb is the brachium, the antebrachium, and the manus. Okay. So the brachium is what we would consider to be the arm, the true arm. The antebrachium is the forearm, and the manus would be the hand. There are a total of 37 bones that form this skeletal framework. The arm itself, the brachium, there's a single bone. It is called the humerus. Notice the way that it is spelled is not humorous like funny. It's humorous. This is going to articulate with the scapula at the elbow and with the bones of the forearm, or the antebrachium, what are called the radius and the ulna. There are some important markings on this bone that we will take a look at, including the head. Remember, the definition of a head is a rounded part that forms a joint, a neck, which is a narrowing. This bone, interestingly, has two different necks, and we'll see those in a second. And then those tubercles. Tubercles, again, are bumps where we have points of attachment. Right. And let's take a look at that. Again, we are looking at a right humerus here. This right humerus from an anterior and a posterior view, so a front and back view. This rounded portion here is the head of the humerus. This nice, smooth head of the humerus will sit on the glenoid fossa, or the glenoid cavity in the shoulder. And when we look at the shoulder joint, we'll see there's actually a lot of soft tissue that holds that in place. Okay, a lot of ligaments that will hold that in place. Those ligaments then will find points of attachment all throughout this region here, where we have the anatomical neck. And the anatomical neck is where the smooth head ends and you have the roughness of the bone beginning. Here we also have what's called a greater and a lesser tubercle. These are thickenings of the bone. Then there's what's called the surgical neck. And the surgical neck is where the thickness of the bone becomes thinner. Right? That's the true definition of neck. So on this bone, it's a little bit strange that we have two different necks. As we work our way down, there is this thickening about midway down called the deltoid tuberosity. The deltoid tuberosity is where an important muscle called the deltoid will attach. In addition, if you remember looking back from chapter 6, we talked about Wolff's Law, where we have a bone that has at the point where it is most likely to break, midway along the shaft, is where we'll see a thickening of that bone. Okay. So that's what we're seeing here. To prevent breakage, we have this thickening of the bone along the midway of the diaphysis. Now down on the lower, what would be the distal aspect of the humerus, we are going to see a lot of complicated structures, and these are going to allow for the formation of the elbow. And what we consider the elbow is actually two very important joints. Let's start over here where we have the coronoid fossa. The coronoid fossa is going to be an indent, and what we'll see is there's a structure called a coronoid process on the bone of the ulna. So there's another use of the word coronoid. So we have a coronoid process here in the jaw, and we have a coronoid process here in the ulna, and we have a coracoid process here in the scapula. So you have to keep those straight. The coronoid fossa is going to be where part of the ulna will articulate. On the posterior aspect, we have something called the olecranon fossa, and we will see something called the olecranon process. We'll project into that. We also have some smooth areas here. Where you see smooth areas on bone, that's often where you have an articular surface. Right? We have a rounded articular surface that is called the capitulum, and the capitulum will be where a bone called the radius will articulate. Then we have this double curved surface here called the trochlea, and we can see the trochlea on both sides, and the trochlea is where the ulna will articulate. These are both considered condyles, right? Rounded parts of bone. Right? They just have special names. So above them we have a thickening of the bone that is called an epicondyle. Right? Epicondyle is a thickening of a bone above a condyle. So we have a medial epicondyle towards the medial, right, towards the center of the body, and a lateral epicondyle towards the outer part. So even though it's not labeled on both sides, you can see the lateral condyle on both bones, on both sides of the bone. So we have a single bone in the brachium. If we look at the forearm, the antebrachium, we have two bones, the radius and the ulna. These will articulate proximally with the humerus, as we just mentioned, and distally they will articulate with the carpal bones, which are the wrist bones. They also articulate with one another. So the radius and the ulna will articulate with each other, and they're going to move in a certain way. Between them, we're going to see a very special kind of joint called the interosseous membrane. And that is going to be what keeps those two bones partially together. So if we look at the forearm now, these are held in place the way they would be. Okay. This would be the proximal end. This would be the distal end. We are looking at a right forearm, anterior, and posterior views. So this is where we would have articulation with the humerus. We'll start off with the shorter bone that has the flattened head. That is the radius. The radius has a fairly flat head. That flat head will articulate with the rounded part of the capitulum. Okay? And that's where we're going to have the ability, it's going to rotate, right, on that capitulum. Below the head of the radius, we have the neck. Then we have a slight bump called the radial tuberosity. That radius continues down, and it's held against the ulna with this interosseous membrane, and there's a little bit of space there. Down at the distal end, this is where we're going to see the formation of a little bracket, and that little bracket is where the forearm will articulate with relatively square bones that make up the wrist. Those are called the carpal bones. On both the radius over here and the ulna over here, we have small process that comes off. These are called the styloid process. Right? A styloid process simply means a thin pointed process. Right? So we see it on both. Notice that the radius is much bigger on its distal end compared to this other bone, the ulna. So let's work down the ulna. Here is the most complex part of the ulna. It's hard to see it on this diagram, but this has a U shape. Right? So the way I remember the ulna is if you look at the shape of the ulna, it has a U right in it, ulna. That U is formed by what's called the olecranon process, which would be towards the posterior region, and the coronoid process, which is towards the anterior region. These will actually, this forms a trochlear notch, right, that little U shape, and that will sit nicely on the trochlea that we saw on the humerus. When you move and bend the hinge joint of your elbow, then, the olecranon process goes into the olecranon fossa, and the coronoid process goes into the coronoid fossa, right? So those words all kind of fit together. Now, we do have a joint here between the radius and the ulna, and we will talk about that in Chapter 8, specifically what kind of joint that is. Then as we move the way down, again, these two bones are held together with this interosseous membrane. At the distal end, we have a much smaller styloid process, right? And we have these two bones held together. The bones of the forearm really need to be held together. You do not want those separating from one another. All right, so moving on from the forearm, then we need to look at the third part of what we consider the upper limb, which is the hand. And when we talk about the hand, we really are talking about the wrist, the palm, and the fingers. Okay? So the wrist bones are called the carpals. The bones of the palm are the metacarpals. And the bones of the fingers are the phalanges. Okay? Singular is phalanx, plural is phalanges. There are 8 of these cube-shaped bones that form the carpals. You can see that they form a region that fits nicely into the bracket that's formed by the styloid process of the radius and the ulna. When looking at the distal aspect of the radius and ulna, remember the radius is larger in its distal aspect, so this is the radius, this is the ulna. Then we have these 8 bones. They occur in basically 2 rows of 4. Now you can't quite see it from this diagram, but these don't sit just flat. They actually create a little bridge almost, it looks like. So if you've ever heard of carpal tunnel syndrome, the nerves that pass through and have to go up to your fingers have to pass through this tunnel that's created by the carpal bones. Okay? And as these nerves and blood vessels and things pass through, if you have a lot of movement here, you do a lot of repetitive motion, you can get inflammation in here, and that leads to something called carpal tunnel syndrome, which is often characterized by tingling and numbness in the tips of the fingers. There are tests that you can do. They're very simple tests, and they have to do with like tapping your fingers if you get like a vibration feeling. The metacarpals are numbered. So starting off with the pollex, the thumb. You have the 5 metacarpal bones. 1, 2, 3, 4, 5. You should be able to identify those. Okay. Then you have the phalanges, and we call the phalanges proximal, middle, and distal. So proximal closer to the origin, distal further away. With the exception of the thumb. The thumb only has 2 phalanges. Okay. So we just have the proximal and the distal. Let's move on then to talk about the pelvic girdle. We're going to start talking about the lower limb and how it's attached to the body. The hip, what we would consider the hip, is actually formed by a pair of bones called the os coxae or coxal bones. These have a very tight interaction with the sacrum. The sacrum, if you remember, is part of the axial skeleton. That's what's going to form the bony pelvis. So when we look at the bony pelvis, we're going to see that it's several bones put together. And in fact, the os coxae or coxal bones are actually 3 fused bones. There is no single bone called the pelvis, just like there's no single bone called the skull. Okay. The pelvis is a complex structure. It is where we're going to see the attachment of the lower limbs to the axial skeleton. It is going to be where we see the strongest ligaments of the body, where we see attachment for strength, because this is where the weight of the upper body, the weight of all movement, is going to be transferred. The pelvis also has to support the weight of all of our internal or viscera. Right? So all of our internal organs or viscera get supported by the pelvis. If we look at the pelvis, let's take a look at where we see the sacrum and the coccyx. Remember, these are part of the axial skeleton. This very odd-shaped bone, definitely an irregular bone, that would be the coxal bone or the os coxae. This bone is actually going to be made of 3 bones that fuse very early on, right, and we'll talk about those separately. What this creates is it creates this nice brim here that is called the pelvic brim. Right. Here you can see the base of the sacrum. So from here above, we would have the vertebral column sitting. So this is where the lumbar vertebrae would sit. This joint over here, we will look at very briefly in Chapter 8. That is the sacroiliac joint, or the SI joint, okay, which is sometimes problematic in people, especially women after they've had a child. Sometimes there's problems with the sacroiliac joint. Okay. This region over here, this is called the acetabulum. This acetabulum is going to be a very deep fossa where we will see the head of the femur articulating. So that's where we'll actually have connection between the pelvic girdle and the femur or the leg. We will see that the 2 bones, the 2 os coxae, meet at the center in something called the pubic symphysis, which is a very special kind of joint. So let's look at each of these bones separately. There are 3 parts. One is called the ilium. The ilium will be the topmost part of the os coxae. It's a flaring region. We'll see that it has something called the body, and then a part that's wing-like called the ala. Right? And we've seen that word before. Ala it means the wing. Now the posterior-lateral surface, so break that word down, posterior towards the back, lateral towards the side, that's called the gluteal surface. Right? So that is the surface of the hip where you see the gluteus maximus, right? Where you see the gluteal muscle or the buttock. This is where we will have the auricular surface that articulates with the sacrum. That's our sacroiliac joint. And there are a few major markings we'll take a look at. So the region that we see here that is the kind of yellow color, that is where we have the ilium. Right? The ilium then, this would be the ala. We see that part of the top of the acetabulum is formed by the ilium. Okay? There's something called the inferior gluteal line. There are many lines and spines. We will not cover them all, but you should take a look at them. And those are going to be places where the major muscle groups will attach. So when you look at the muscles in A and P2, those will become much more important. Now if we take a look at the medial view, now we're looking as if we pulled the hip out of the body. Okay. This auricular surface, this is where we have articulation with the sacrum. Here again we have the ilium. This is the curved inner part called the iliac fossa. So this would be what we see if we take the pelvis apart and look at each of the hip bones or the coxae separate. Now, the other two regions down here shown in pink and blue are the two other bones that fuse to form this. Okay. One is the ischium. The ischium forms the posterior-inferior part of the hip bone, so the back and bottom. It is a relative thick body that articulates with the ilium, and then it has a thinner ramus or branch that articulates with the third bone, which is called the pubis. The pubis then is the bone that's towards the front. It is the anterior portion of the hip bone. Okay. It articulates both with the ischium and the ilium. And it is going to create something, when they all come together, they're going to create something called the obturator foramen. So it's easier to look at these kind of together. So now we are looking at that lateral view, so we're looking from the outside in. We see the acetabulum. The acetabulum is a very key marker. If you can find that on a coxal bone, you can get your bearings, you can get your positioning. Okay. This part that is the pubic body is going to come in towards the front. It's going to create the front part of the pelvis. It has a thicker part that's going to create the acetabulum, right? And then it curves around, and what it creates then is this big opening here, and that opening is called the obturator foramen. Right? It's a very large foramen. It's called the obturator because we will see that a nerve called the obturator nerve will pass through it. So it is the foramen for the obturator nerve, hence the obturator foramen. This back region here, this is going to be the ischium. Right? Let's look at the front part. Right, so now we're looking at the medial view. Here the pubis is coming in. Right? We see an articular surface here. This is where one pubis, the right pubis, will articulate with the left pubis. Okay? And we'll see that as something called the pubic symphysis, a very special kind of joint. The ischium then, the ischium forms the back part and the lower part, so basically it is your butt bone. Right? It is the bony portion that you would sit on. It is quite thickened. And that is going to also form part of the acetabulum. And in terms of the overall pelvis, the pelvis is a very important structure. We can now see these three regions, right? This would be the ilium, this would be the ischium, this would be the pubis. We now have these together where that auricular surface is forming the sacroiliac joint. The two pubic arches are meeting at the pubic symphysis, okay? And so we've created this space here, which we're going to call the pelvic brim. This has a really important function, and it's going to lead to there being a difference between male and female pelvic structures. It's one of the most obvious differences between the male and female skeleton. The reason for this is, in order for a female to give birth, the fetus has to pass through the pelvic brim. The fetus has to be able to pass through. So when we have that differential development of bones, usually starting about puberty time, okay, the bones will develop and actually take on slightly different shape. So the female pelvis is more tilted forward. Okay. The birth canal is going to be wider. The overall organization of the hips is going to be more broad, so they flare out more, okay, giving the pelvis a greater capacity. Compared to a male pelvis, which is normally going to be more narrow, the pelvic brim or opening is going to be more narrow, V-shaped or heart-shaped. It is more adapted for carrying around heavier muscle and the bigger build of males. Most males have a larger physical build than females, and they don't need to have a big pelvic brim because they don't pass babies through. If we take a look at a comparison of a male and female pelvic structure, look at these and try and determine, based on that, which you might think would be the male pelvis and which would be the female pelvis. The female pelvis, we are looking at a very odd position right now. We are basically looking at a position if we were lying on the floor and looking up. Okay. So we're really seeing the pelvic brim quite clearly here. This opening is large enough and suffices for a baby's head to pass out. This would be a male pelvis. It does not. The other thing you should notice as far as the tilting, if you look at the edge of the pelvis here, specifically the ischium here, and the coccyx, there's a distance between them. Whereas on the male pelvis, here's that edge of the ischium and the coccyx, and they are in line with one another. Right? So we have a much more narrow opening here between the for the male pelvis versus the female pelvis. If we were to take a look at a forward view, female hips also tend to be wider and a bit lower. That does have some interesting consequences in terms of the way the femur articulates. So the femur actually articulates in on a bit more of an angle here, whereas with males, the femur would be more straight up and down. Hence the reason if you see a woman standing at rest, the feet are usually fairly close together and the legs angle inwards, whereas if you see a man at rest, they tend to stand with their legs, their feet further apart and their legs, their femurs more straight down. Now again, this is not 100%, right? There are some males who have more feminine-like structures and females who have more male-like structures, and there's a huge range here. So this is not like a one or the other type thing. So if you are trying to compare between two different pelvic structures to determine which one is male, which one is female, there are certain key things that you would look for. The first one would be how wide and circular is the pelvic brim. So if you have a big, wide, circular opening, that's likely female versus a narrow heart-shaped or triangular-shaped opening, that's more likely male. The other thing you would look for would be the distance between the tailbone or the coccyx, okay, and the ischium here. So we have a good distance between these 2 points, as opposed to in the male, they are usually not as necessarily touching, but in the same plane. Those are 2 of the really key points that you might see in comparing a male and female pelvis. This chart just gives you a nice overview for studying purposes of what the differences would be between a male and female pelvis. So I think visual representation is probably better. So now we'll work on the lower limb. The lower limb has 3 main parts. We have the thigh, which is going to be the upper part of the lower limb. The leg is the region from the knee to the ankle, and then the foot, which includes the ankle. This structure, we're going to see a good deal of strength here because it has to carry the weight of the body, and it has to withstand lots and lots of forces and pressure whenever we are walking, jumping, running. So we'll start with the femur. The femur is the sole bone of the thigh. It's the largest and strongest bone of the body. It will articulate proximally with the os coxae, specifically in the acetabulum, and distally it will articulate with the tibia and the fibula. We'll look at the major markings. Again, we are looking at a right femur here from the anterior and posterior aspect. The rounded portion here is the head. We see that it is quite round, quite smooth. There's a little indent in the top called the fovea capitis. That fovea capitis, when we look at the joint and the ligaments in Chapter 8, we will see this is where a very important ligament called the ligamentum teres attaches. Beneath the head, then, we have this thinner region here, which is called the neck. Then we have this large projection here. This is called the greater trochanter, right, and the lesser trochanter. And you can see the greater and lesser trochanters from both the posterior and anterior aspect. We also have the intertrochanteric line. Right? This is a line that you would see between the trochanters. In the posterior view, you will see this tuberosity called the gluteal tuberosity. This is where we'll have a site of muscle attachment. The front, or the anterior aspect of the femur, is fairly smooth. On the posterior aspect, we see a line called the linea aspera. That linea aspera is going to split into these 2 lines called the medial and lateral supracondylar lines. Okay? And these lines will end up just above condyles. Okay? So we have condyles here. We have a medial condyle, which is towards the medial point on both sides, and the lateral condyle. Just above these condyles, we are going to see an epicondyle, so we have a medial epicondyle and a lateral epicondyle. In the anterior view, there is a smooth surface here called the patellar surface, and this is where the patella will articulate. The patella is the kneecap. It is a very unique bone that's called a sesamoid bone, and it actually forms within the tendon that connects the quadriceps muscle to the tibia. The condyles here are quite rounded. Right? In between them, we have something called an intercondylar fossa. Okay? This intercondylar fossa will be the point of attachment of two important ligaments that we will talk about in Chapter 8, called the anterior and posterior cruciate ligaments. So this distal region here, this is where we will see the articulation of the tibia. The tibia and the fibula form the skeleton of the leg. So the lower part of the lower limb is the leg. As with the radius and ulna, these are interconnected by interosseous membrane. They articulate with the femur proximally and with the ankle bones, or what we call the tarsal bones, distally. And they interact with each other through what are called the tibiofibular joints. We will see all of those joints in Chapter 8. The tibia is where we have the weight bearing of the leg. Okay? It takes the weight that's being transmitted through the femur and it transmits it to the foot. The fibula is not weight bearing. Right? The fibula does not bear weight. The fibula is very fine. It's a very fine bone, right? And it is not a very strong bone. Okay? Looking at the tibia and fibula, this would be a right tibia and fibula. There are two condyles here. This is where we would have the articular surface for the condyles of the femur. Okay, so that rounded portion of the condyles of the femur would sit right here and here from the posterior view. In between, we have this projection that comes up that is called an intercondylar eminence. Okay, the intercondylar eminence would line up with the fossa, and that's where we would see the origin of those two important ligaments. On the very front of the tibia, we have what's called the tibial tuberosity. This is a site of important muscle attachment. Okay. The tibia is a fairly thick bone. The front of the tibia, if you run your finger down the leg, would be what you would call the shin. So the tibia is the topmost bone, right? You feel that on top. Following the tibia down, once again, we do see this thickening towards the middle. Then at the distal portion, we have a process that we call the medial malleolus. So the tibia is medial towards the center. The lateral malleolus is part of the fibula. Though this is what, if you feel what we would say the ankle, like the bony projection that sticks out of your ankle, what you are actually feeling is the tibia and the fibula. You're actually still feeling part of your leg. The true ankle bones, which we'll call the tarsal bones, will sit in this little bracket that's created. And that bracket is what is going to allow the foot and ankle to move relative to the lower leg. Now the fibula is a much thinner bone. It is not weight-bearing. The fibula sits slightly towards the back, slightly posterior and lateral to the tibia. It articulates in. The head of the fibula sits in a slight notch that we see on the posterior region of the tibia. It's a fairly thin bone. We do see these being connected, once again, like with the radius and ulna, with this interosseous membrane. Interosseous meaning between the bones. And then we see the lateral malleolus coming down. Most people who fracture their ankle, or they say, oh, I broke my ankle, they actually break the fibula. Okay? It's not a break of the actual ankle bones. Rather, it's a break of the fibula, which forms the bracket that creates the ankle. The fibula doesn't have a lot of important structures on it, but you really need to understand where it's positioned. Finally, we have the foot. The foot has a very similar organization to what we saw in the manus, or the hand. Okay. The foot includes the bones that we would consider the ankle bones. Okay. The ankle bones are called the tarsal bones. Okay. There are 2 tarsal bones you will have to know. There are a total of 7 tarsal bones. Okay. The 2 that you will have to know are the talus and the calcaneus. Okay, the calcaneus is the bone that projects downward. That would be the bone of our heel. The talus, then, is a bone that sticks up, and this is where the bracket formed by the medial and lateral malleolus of the tibia and fibula are going to rest. The other bones, then, are called the cuneiform bones, the cuboid and the navicular. I will not be testing you on the names of those bones, but you should learn them. The other thing we have are the metatarsals. Okay, the metatarsals would be the bones of the foot proper. Okay. They are numbered 1 starting with the great toe or the hallux, 2, 3, 4, and 5. Then the phalanges, all right, which form the digits of the foot. We also have proximal, middle, and distal. Okay. We have those for the four digits, and then the hallux has 2. The organization of the foot is extremely important because it supports the entirety of the weight of the body. It also levers your body so that you can walk. If we take a look at the medial and lateral view, okay, the foot has within it a specific arch that we will mention, okay, and that arch is formed by the interaction of the calcaneus, okay, with the other tarsal bones. The calcaneus bears a lot of weight, so we have this thickening here called the calcaneal tuberosity. There's actually quite a bit of important tendon and ligament attachment here that holds your ankle in place. Okay. This is the talus. Here we have the facet for the medial malleolus. Okay. And on the other side, from the lateral view, we have the facet for the lateral malleolus. So this is where the malleolus of the tibia would be, and this is where the malleolus of the fibula would be. Those metatarsals then form the majority of the main part of the foot, and then you have the digits of the foot. The arches of the foot, there are 3 main arches that the feet should have. The arches are what are going to allow the foot to hold weight. So we have 2 longitudinal arches. Those are arches that run the length of the foot from heel to toe. Right? We have the lateral towards the outer portion and the medial towards the inner portion. And then we have the transverse. Those 3 together create the proper arch, and what that arch does, that arch keeps the talus projected in a way that it does not put additional pressure on the tibia or the fibula, okay, and allows the weight to be transferred solely down through the tibia. Okay. You don't want weight to be put on the fibula. The fibula is not meant to be weight-bearing. All right, so let's take a few minutes now and look at the developmental aspects of the skeleton. Specifically, we're going to look at the fetal skull. We had mentioned that the bones of the skull are going to develop through a type of ossification known as intramembranous ossification. So within the fibrous membrane that makes up the embryonic skull, as it becomes bone, we will have several different points where we have primary ossification centers, and the bones will basically grow out from there. What that means is that the bones that we have as an adult, the frontal bone, the parietal bone, the occipital bone, the temporal bones, are not fully developed in fetuses and then in infants. When we look at a fetal skull, the development is incomplete, and we have spaces between the bones. Right? These are what you would say is the soft spot on the skull of a baby. Okay, these are called fontanelles. The fontanelles are the unossified remnants of the fibrous membranes between the fetal skull bones. There are 4 main fontanelles: the anterior, the posterior, the mastoid, and the sphenoid. So if we take a look at a fetal skull, here is the frontal bone, or what will become the frontal bone. This would be the anterior fontanelle. This is the soft spot on a baby's skull that you may have seen if you've ever held a small baby. This occurs between the frontal bone and the parietal bones. The other interesting thing is the frontal bone actually starts out as 2 different points of ossification. So there is a frontal suture which will close and create a solid bone. Okay, so we have a solid bone here. You do not see any frontal sutures in an adult. The ossification centers in the parietal bones then spread outward. This will eventually become the sagittal suture. This will eventually become the coronal suture. Right. At the back, we have a much smaller fontanelle known as the posterior fontanelle. On the side view, we have the sphenoid fontanelle, which is where the sphenoid bone will eventually grow up and close. And then we have the mastoid fontanelle, which is in the mastoid region of the temporal bone. When we look at a fetal skull in lab, we will look at a plastic model of a fetal skull. There are a few things that you will note Right? You should be able to identify these different fontanelles. You should note also that the arrangement of the bones is the same in a fetus, okay, but there are some differences. If you think about a baby's face versus an adult face, right? Babies have cute little scrunched up faces, tiny little mouths, and big giant eyes. Right? That's typical of any baby. Right? That's what gives babies that cuteness. When we look at the facial bones of a fetus versus the facial bones of an adult, we see a huge difference. The bones are present, but they are much different. The mandible has almost no ramus. The maxilla and the nasal bone are present and they're in the right orientation, but there's a big difference, especially in the mandible. What we're going to see is as growth occurs in a normal baby up through life, we see differential growth rates. Okay, so not all bones in the body grow at the same rate. Not all bones in the skull even grow at the same rate. When at birth, the cranium is huge compared to the face. Babies' brains are actually quite large, right, compared to the rest of their body. So if you look at a newborn, right, a newborn is about a quarter head and 3/4 body. Imagine what we would look like if we were 1/4 head and 3/4 body. As we grow, the limbs grow the fastest, followed by the torso, right, and the head actually does not grow very much. The head does not grow very much. Instead, we see differential growth rate in the skull. So if we were to look at a human newborn, right, and look at the different bones, and then measure how they grow over time, we will see the majority of the growth is going to occur in the mandible and the maxilla, and that's what creates the adult face. Okay? The adult face is much more elongated. The jaw is much larger. Okay? Some of the bones grow very little. The areas where you have your ossification centers of, say, the parietal bone doesn't really change in size much. The overall parietal bone does grow a bit because we see it growing to close those fontanelles. Okay? We see it growing to allow for the development of the brain. Right? We see a bit of growth here in the frontal bone, right, which creates that forehead. We have a much more domed forehead than babies do. So we see different growth rates in the bones in both specifically in the skull, really, really clearly in the facial bones, but then as we look from newborn through prepubescent to pubescent to finally adult. Now the change of growth in females especially from prepubescent to pubescent to adult is fairly limited, and most of the change seen from that age throughout puberty is not growth in size, but rather change, and that's where we see our sexual differentiation between males and females, where instead of growing in stature, we see some changes in the bone that give us our male typical and female typical body types. Another important change that occurs from birth through growth has to do with the spinal curvatures. So if we think back to the axial skeleton, the spinal curvatures that we saw in the cervical vertebrae, we have a curvature. In the thoracic, we have the opposite curvature. So we have a curvature towards the front, curvature towards the back. The lumbars curve towards the front, and the sacral curve towards the back. Okay, these are considered primary and secondary curvatures. So the primary curvatures, these are what are considered convex posteriorly, so they curve towards the back. Right? Those would be the thoracic and sacral curvatures. The secondary curvatures, which would be the lumbar and the cervical, which curve forward, are not present in infants. Right? So if you look at the way an infant's back curls, the reason infants can do that amazing thing where they can basically take their knees and put their knees to their ears, okay, their spine is only curved in that way. The two forward curvatures of the cervical vertebrae and the lumbar vertebrae really don't start developing until a child is up and walking. Okay? That's actually what starts creating those curvatures. The curvature that we have, that forward, backward, actually allows us to stay upright. Okay? If we had a straight upward spine, we actually would not be able to stay upright, right? Because we have more body towards the front than we do towards the back. The only way we could stay straight upward if we had a straight upward vertebral column is if it was in the actual center of our body. Okay. So that forward, backward curvature allows us to be anchored and stand upright. Now, you don't see those spinal curvatures in children until they're up and walking, and this is one of the reasons why now child development specialists recommend not forcing infants to walk, right? Allowing them to get up and walk, and also things like those bumbo chairs and those walkers and those sitters that force a child into the sitting and standing position are not as good for the development, right? Because their body, their physical development isn't ready for them to have that motor development, for those of you that are interested in child development. Now, as we age, on the other side of things, as we get older, there are some changes we will see to the skeleton in terms of old age. One of the big things is the intervertebral discs become thin. Right? They lose hydration, they become less elastic, and they become more likely to herniate. When we have herniations of the disc, we can have compression of the spinal cord, the spinal nerves, which we'll see in chapter 12 and 13. There is some degree of loss of stature after age, say 55, 60, 65. It is getting higher and higher as our medical care increases. That is becoming a much greater age. The reason that there is actual loss of stature is two things. One is a stooping, right, where the stooping. I don't know if stooping is the right way to say it. When you begin to actually curve over, right, due to weakness, right, you get females sometimes get what's called the dowager hump, right, and that's due to an additional curvature of the spine. The other thing is, as you lose a small amount of the hydration of each of those intervertebral discs, you have more compaction of the vertebral column, and that will lessen stature as well. The other thing that occurs is, remember, we have the hyaline cartilage and our costal cartilages, okay, and that can begin to ossify. That makes the thorax more rigid, right? That's another thing that's going to reduce the ability of the rib cage to expand and contract. Right? All bones start to lose mass with old age. We mentioned some of the ways to prevent this or limit this in terms of having diets high in vitamin D, calcium, phosphorus, to allow for that bone to be maintained.